Our next case will be presented by Shawna Wheeler. Shawna is a PA at the UW Ortho Bone Health team, and she is running point on dealing with a patient population that our field has largely done a really bad job with, and that is spinal cord injury. And she'll be talking about a fracture in a spinal cord injury patient.
Hi, I'm Shawna Wheeler. I'm a physician assistant with the Orthopedic Bone Health Clinic, and I am endeavoring into treating patients with spinal cord injuries. And I saw this gentleman, 43-year-old Black male, whose status post T7/8 spinal cord injury back in July for the first time. And he had had the unfortunate event to be shot multiple times, like 13 times in November of 2020. And then switch slides. I'm on bone changes after SCI. Okay, so interestingly, diffuse osteoporosis starts very, very quickly within the first month of the spinal cord injury. And there's a lot of really good information through here as well, but I wanted to highlight just a few things. Within 2 to 3 months, they actually become more likely to have fractures and lots of stuff in here, month 4 to 6, but I want to show you that even some partial recovery may be feasible if we can get them into some weight-bearing exercises to help slow bone loss. And regardless of what we do, there seems to be a persistent fracture risk, even with minimal trauma. And then a year and beyond, it's really important for us to consider treating with medication management. Oh, I'm sorry. I keep forgetting to say switch the slide. Diane, can you hear me at all?
You're right. She's on the right one, I think. Bone changes,
Perfect.
chronic.
Yes, chronic. Yep, 1 year and beyond.
Okay, she's on it.
And okay, perfect. Thank you, Diane. See, she's great. And next slide, please. So luckily, our gentleman goes to physical therapy for daily functional rehab, uses a wheelchair to get around, but he's able to transfer on his own. In April of 2025, he was working on hip stretching exercises with his physical therapist. Physical therapist had him in a figure 4 position and pushed down on his knee just to stretch his hip a little bit, and he heard a pop. And then he luckily was able to get an x-ray right away, and it showed a femur fracture. And you can't see
Okay.
it in the left one, but you can definitely see it in the next two. And you can actually almost see where the cortices, where you almost could have guessed where he was going to fracture because the cortices get really, really thin, especially on that third side, third picture, you can see that. Well, once he got to UW, he was seen by Dr. Donahoe, who helped him get an intramedullary nail. Interestingly enough, his fracture was in April, and then these slides are from July. And so you can still see that fracture fairly well. Okay, next slide.
There's no callus, right?
Yeah, there really wasn't a lot of healing at all at that point. Um, and so this slide says case presentation. So I saw him in July. He has a history of neurogenic bowel and bladder, autonomic dysreflexia, which is a very high blood pressure response to certain events, including fractures that can actually be life-threatening. He's had a pressure injury of his skin, and these are medications that he wasn't on before he had his spinal cord injury. We usually do a pretty good nutrition evaluation. Found that he was getting about half, maybe even a little bit less of what he should be getting. His vitamin D in the hospital when he was being treated was 9. And that's an acute phase reactant. So we would anticipate that it would be a little less than normal, but not probably nanogram per milliliter. He gets good protein intake. He doesn't drink coffee or soda. He doesn't smoke, doesn't drink, and he hasn't fallen in the last year. We usually do some labs on our patients, and to show you this informative tidbit, about 30% of patients who are getting pharmacological treatment for their osteoporosis have undergone laboratory evaluation for secondary causes of bone loss. And interestingly enough, when you check those patients, about 64% had at least one abnormality, most common being hypogonadism. And if you take a look at these labs, his testosterone was down near the lower end of normal, and we already knew that his vitamin D was low. Next slide, please. Like Dr. Anderson had discussed, we didn't have a bone density yet, but we had a bunch of CT scans. And so, interestingly enough, 5 years before his spinal cord injury, he had a car accident. CT Hounsfield units were 324. Then at his initial injury, they had, for some reason, gone down to 258. Maybe it was because of low vitamin D. It's hard to know. Low calcium probably might have played a role in that. In 22, he had some hematuria, so we got a peek at that, and that's going down again. And then in August of this year, he was seen for thoracic numbness, and his CT Hounsfield units are down to 188, 189, which is still normal, but the trend, and I don't know that we actually know how to measure this decrease because they're all still normal, but I don't think that the trend looks amazing with this opportunistic CT. Next slide, please. So treatment for patients with spinal cord injury is still kind of up in the air. It seems to be effective in reducing bone loss in spinal cord injury with the alendronate, but not quite as well as in patients that don't have a spinal cord injury. Bisphosphonates reduce fractures in able-bodied individuals, but hasn't really been shown yet in patients that have spinal cord injuries. And we're not sure whether or not they improve sites like the distal femur. Denosumab seemed to reduce bone loss at the hip and lumbar spine in spinal cord injury patients after 1 year. But we've already talked about where denosumab can get us if we're using that longer term. Let's see, next slide, please. Medication treatment. So PTH anabolics don't seem to be very effective unless patients are weight-bearing. And Romosozumab, I think we'd had some hope that would be effective in patients that might even be non-weight bearing, but there doesn't seem to be really any good evidence that it's much better than the PTH anabolics in patients that aren't weight bearing. Next slide, please. So what can we do? Well, we need to start somewhere. We're starting with calcium, vitamin D, talking about lifestyle, making sure that patients don't have other reasons that they could have low bone density that could put them at increased risk of fracturing. We're looking at trying to tailor pharmacologic therapy. Still don't know exactly what that means. My patient had been doing standing protocols, and I'm actually quite hopeful that he'll be able to get back to that. Whether or not we try an anabolic in that setting, I'm uncertain, but that may be something that we could consider because he does stand. And so I saw him in first follow-up in August of 2025. I'd spoken with his primary care provider, and she's going to be looking into that low normal testosterone. I started him on a little bit of calcium citrate. He had, I had given him information about his labs about a week before I saw him, and he had already gone out and got the vitamin D 5,000 units and was taking it. We plan to see his bone density results in October, and we'll recheck his labs in October as well, because right now his low vitamin D is the main reason that we're not able to treat him at this point. And then I'll see him in early November. These are some key takeaways. patients lose a lot of bone in that first year. It's a window of opportunity to help reduce their bone loss if at all possible. Unfortunately, we don't know how to best evaluate their fracture risk because they break things that are different than our regular patients. They're always at risk for fractures. Fracs may not tell us the whole story about their fracture risk because we aren't looking at those other areas in their body that they do fracture. They're very vulnerable to fractures and they're underserved. And we really don't have a lot of amazing diagnostic protocols or evidence-based treatment guidelines, but we do have this. The Paralyzed Veterans of America has put out some clinical practice guidelines, and they have a nice diagram for how to start evaluating patients. I went through and found the best benefits versus risks evaluations that I could with the Paralyzed Veterans of America and put them on the next few slides. Things to do for medication history, fall and fracture risk. Next slide, DEXA evaluation. Next slide, more on DEXA evaluation. Next slide, interesting things on peripheral quantitative CT. I am not familiar with that, but the Paralyzed Veterans of America seem to be pretty enamored with it because they have some pretty good recommendations for using that. And the next slide is also on PQCT as well. Calcium and vitamin D guidelines. Rehabilitation therapy. They use a lot of neuromuscular electrostimulation. I don't know that we have the capacity to do that in a lot of our patients at this point, but maybe that's something to look forward to in the future. They seem to think that it has strong recommendation and moderate quality evidence, so that may be a place to head. And then drug treatment. And basically, they want us to identify that spinal cord injury patients are at risk for fractures, and then a fracture does indicate osteoporosis in a spinal cord injury patient. And then, any questions?
Thank you, Shawna. That's really important because I never know what to do with these patients. That was really informative. I have a question about the anabolics and what you alluded to, not working in people that don't bear weight. How much, I mean, I saw the reference, I think it was Edwards that I'm going to look up. When I look at this, there doesn't seem to be much literature.
No, there really isn't, but I think that there's some that suggest that there's not a lot of gain in patients taking anabolics unless they're bearing weight. And I don't know that there are a lot of studies in particular that have spinal cord injury patients that do the standing and some weight bearing, and whether there's a difference between those patients and patients that aren't weight bearing.
Yeah, Joel, I don't understand the pathophysiology, and maybe somebody on the Zoom tonight does, but Bob Recker told me in 1993 that the PTH anabolics were not going to work without loading. And the limited data that's out there suggests that they don't help in the femur,
Right.
distal femur, which is where they break. And there's a recent publication, I think also out of the Northwestern group in Chicago with Romo, that showed the same thing.
Now that kind of surprised me because so I'm going to have to look up that paper because I'm not aware of it. I have been using Romo in these patients and maybe wasting it.
Well, and I think it helps their spine, um, but and that's probably good. But bending your leg and snapping it is not good.
Yeah.
And
Yeah.
so
The question is, will anything prevent that?
Can I
I
say
don't
a few
know.
things?
Pharmaceutical.
Not that we know of as today. I think it needs to be somehow done in concert with some way to try to load the femur.
So, I mean, standing machines are used frequently by patients and can either, I don't know how they're paid for and all this other stuff, but I have some of my patients have standing machines, and my assumption is if they do that several minutes a few times a day, that makes a big difference. But I don't know that to be true.
Yeah, but they're not widely available and they're actually risky. People crash and burn on those things.
Oh, really?
Well,
Yeah.
I have one downstairs, so I have some familiarity with them. They are hard to get paid for. Medicaid is pretty stringy about them, and many patients who need them on Medicaid. Private insurers with a firmly worded letter will sometimes cover it.
Yeah. Let
They're
me,
they're pricey. Um, but yeah, I would say that my experience is mostly in our CWC population locally in Madison. In terms of caring for bone health of people who basically are non-weight bearing is sort of more that area of profound intellectual disability. And I've tried everything, and sometimes it works a little bit, and I feel like better than nothing, but it doesn't work. Obviously, we know it doesn't work great.
Yeah, this is Chris Morgan. One thing that Shawna didn't mention that she has done, and this is a great example of collaboration, is working in tandem with the rehab doctors and now setting up a pathway to get to these patients early if possible, because the most rapid bone loss is in that first 6 to 12 months. And if theoretically you get a bisphosphonate in early enough, it may be more useful, whereas many of these people don't get to bone provider till it's kind of almost too late, where the rapid bone loss is already kind of stabilized. So the idea of collaborating in pathways to get to them early, I think, is a really great.
I think that's a really good idea. I mean, maybe everyone who has a serious spinal cord injury should get one dose of ZA.
Yeah.
Kind of like becoming weightless and getting up as outer space and getting something to prevent bone loss.
yeah, let me say a few things. Femur fractures, a spinal cord injury patient. My goal was to try to treat them without having a major complication. That was my mindset. So these are absolutely disasters and can kill people very readily. They get decubitus ulcers, urinary tract infections, obstipation, the autonomic dysreflexia, uh, and they are disasters. Um, there are competing things you have to worry about when considering treatment in this acute spinal cord injury patients. Is one of the major causes of death and morbidity is renal failure from kidney stones and bladder stones that subsequently end up with urosepsis. Remember, this patient has a neurogenic bladder and bowel. So if you're going to use an anti-osteoporotic drug, it better not be one that's going to cause hypercalciuria.
Mm.
Yeah. So they resorb a lot of bone. They get hypercalciuric, and sometimes usually young males who have a lot of skeleton will get hypercalcemic. So ZA would actually help prevent all of that.
You would hope.
It
Uh,
it
the,
it,
the,
it makes sense. I think Chris is right.
yeah.
I
The
think
other thing is these are most commonly caused during transferring. For a spinal cord injury patient. And it's the rotation of the legs first, and then the pelvis follows, then the spine follows. And if they get hip stiffness, then this is when they're really susceptible to fractures. That's why frax is useless in this population. Bone density of the spine doesn't tell you a darn thing because they're weight bearing in the spine. And I don't recall ever seeing a spine fracture in a spinal cord injured patient long term. Now we see something called the Charcot spine all the time, but that's a different kind of condition. So you have to worry about that. And one thing I always thought that if you had a patient with a fracture, they need to go back to rehab and be retrained to make sure they are transferring in the safest way possible. It may change how they transfer. A lot of patients who may be out 5 or 10 years have, like this patient, have learned how to transfer and they actually don't want to change, even though it's causing harm to them. And so you really need to work with, a lot of times it's take inpatient rehab to do this. Problem is trying to get funding for inpatient rehab is increasingly difficult. The other thing the hips get is heterotopic ossification. Now, I don't know where that fits into the scheme of metabolic bone disease. I keep asking Neil that, and he keeps giving me blank stares about that. But, and I don't know what these drugs do for that condition, pro or con. I don't think I would want a bone forming drug because it's impressive how much bone they can form when we resect the bone. We can fill up an emesis basin with bone. That's like the greatest bone graft in the world. And it looks like remodeled cortical bone sometimes, spanning the pelvis to the femur. So those are just my comments. Um,
Yeah,
it's
I think
hard
it,
in the acute phase. There's so much going on with that patient to
yeah,
try.
in the interest of time, I think we need to move on. An incredibly challenging and understudied group. I think this might actually be something that you can get some research funding to study. Um, so thank you, Shawna.